So welcome to our our webinar this evening, sponsored by BioLace on implant placement as far as complications, directions, conditions. We have two very good presenters tonight, and I'm going to introduce both of them to you. Dr. Dyer will be first. Bret is actually in Fort Bend Periodontics Implantology, which is actually Sugarland, Texas. And he's a graduate of my school, University of Texas Dental Branch at Houston, diplomate of the American Board of Perio. One thing about Bret is that he is one of the pioneers when it comes to this erbium chromium YSGG technology. And any of you out there that are using that technology to perform perio procedures in what we call the cementum-mediated new attachment procedure, Bret actually did the research for that, the clinical research that resulted in us getting that FDA clearance. And so with that, actually Bret has been my mentor. I went to all of his courses before I began to formulate any kinds of protocols. So Bret, we're anxious to see some cases and see some of your insight in managing this epidemic, which is sort of becoming an epidemic thing of implantitis.
Thank you very much. It's an honor to be here tonight. I've placed my email on the screen. And so if you have questions or if you want to share cases and want some feedback and stuff like that, you're welcome to email me. I'm glad to respond back. I will tell you that I think, let's see if I get this to switch. There we go. I think managing peri-implantitis, it used to be just a few short years ago, a weekly thing. And today, managing peri-implantitis is a daily thing. I'm shocked at how much we really do manage. And the statistics, I don't really think bear out what many clinicians see in their practice from day to day. We really do see a new peri-implantitis case each and every day of the week. And so many of the cases, I think, could have been avoided. And so to start with tonight, things that I think will make a difference in your practice, or at least that they have in my practice, is we use a lot of toys to try to manage these cases. And the first one that I like to use is called the TechScan. The TechScan is an occlusal pressure device. You plug it into the USB of the computer in your operatory and have the patients bite on a sensor, and it'll show you how much force is on each individual tooth and where on that tooth the force is. And so on implant restorations, we make them have 25% less occlusal force than the adjacent teeth. Natural teeth the periodontal ligament allows them to move in the socket slightly. And of course, implants are ankylosed, so there's no movement. And so I don't know about your patient population, but mine, I seem to have a lot of clinchers and grinders. And so if you don't adjust the occlusion correctly, you inevitably end up with broken screws, chipped porcelain, and these saucer defects around the implants. So I highly recommend this TechScan device. It just gives you 3D diagrams showing you force, and there's movies that you can make with it. And I would also recommend that when you're restoring your implant cases, look at the occlusal force and where they are. A lot of times we were trained in dental school to tripod our contacts. I would tell you, instead of tripoding your contacts on an occlusal surface, avoid inclines. Avoid inclines if possible. Try to stay on cusp tips and in central grooves, central fossa. If you align the force of occlusion along the long axis of the implants, over time, you have a lot fewer problems. The other thing is to recognize that peri-implant mucositis, which is basically gingivitis, bleeding on probing, when you see that around natural teeth and you don't see bone loss, you're thinking, oh, I just need to clean the teeth. I just need that patient just needs some oral hygiene and some cleaning. when you see that around dental implants, that implant is infected. And you don't know how fast that infection is going to move on an implant, but we know that peri-implant infections move much faster than infections around natural teeth. And so in our practice, when the patient's coming in for routine care and we see bleeding on probing, we treat that very aggressively. In our practice, we would clean the entire oral cavity, and then we would use the diode laser on the areas with bleeding on probing around an implant. And then we bring the patient back in a month to verify that we've eliminated that inflammation. I think that's when I think about recall and maintaining implants over a course of a patient's lifetime, I think that's the most important thing that we can do, not the cool regeneration procedures that we do or those things. I think if we can prevent it from occurring, that's much more valuable. So, and other things that we see all the time are implants that are placed too close together. You know, if you've got an implant that's 1-2 millimeters away from the next implant, that's inevitably going to have bone loss over time. It's one thing to be 1.5-2 millimeters away from a natural tooth, but from another implant, what then happens is over the course of time, the papilla between those two implants shrinks away if it's there at all. And then they start packing food there. And then they start getting these angular defects. And once they get in the grooves of an implant, you end up with circumferential bone loss. Proper embrasure spaces. The embrasure spaces need to be triangular, not really sharp and tight. When we're placing implants and then they go to our referrals to restore, we're always thinking about, and this is what I emphasize with our referrals, make sure that the bottom of the interproximal contact is not more than 3 millimeters from the crest of bone interproximally. And you want that interproximal space to be a triangle, not a really tight, narrow piece, because that'll cause the papilla to resorb over time. And then they'll pack food, and then they'll have bone loss. Another thing that we always like to keep in mind is the thickness of keratinized tissue around an implant. When we're placing an implant, or even before, if the site for the implant, if we don't have at least 2 millimeters of bone facial to the implant, and then I want 3 millimeters of keratinized tissue to be around the implant, and a volume above the implant, another 3 millimeters of keratinized tissue. So around the periphery of the implant and occlusally above the implant, I want 3 millimeters of keratinized tissue. And today it's so easy to do that with technologies that are available. We routinely use a product from Geislich called FibroGuide. And when we're placing implants, if the tissue is not thick enough, it's very easy just to make a little pouch around the implant and slide this FibroGuide material in and around the implant. It changes over time. It'll change the phenotype of that tissue. Even if it's mucosa, it'll turn keratinized over the next year or so. And it gives you that thickness that won't necessarily resorb away. So I highly recommend that you think about site preparation. We found that probably one of the biggest things that we've noticed in our practice is not so much that I'm worried about smoking, but I'm concerned about patients if they've had periodontal disease in the past. To me, that means they're always going to have periodontal disease. And so we, regardless of their status at the time of implants placed, if they're stable and healthy, or and hopefully they are, you don't really want to place implants in the site of infection. But we bring those patients in every 3 months for cleanings, and we do that forever. And most patients, if we sell them on that before we place the implants, we tell them, look, your implants can last a lifetime, but this is what you have to do to make that happen. And the other thing that we've found that has made a huge difference in our practice is making sure patients have enough vitamin D, vitamin D3. We want them basically to supplement with a minimum of 5,000 IUs per day from the time of extraction to the time the implant's restored. We make sure that they're supplementing with vitamin D. I'll tell you, in our practice, so we've been keeping statistics on the implants that we place since 1991. And we've had a 3% failure over that time frame. And I think a lot of it has to do with, one, make sure our tissue thicknesses are good, and now making sure that they have adequate vitamin D. Another thing is when your hygienist is cleaning an implant, it is so easy to scratch these things up. Regardless of whether you have a tie base or a zirconium base, if they're using metal instruments around the abutment and the implant, they scratch it all up. And all these scratches create a nidus that attracts plaque accumulation. So I recommend that we use this. These are tips from Parkel. They're really good for cleaning around the abutment of an implant and to the top of an implant. On the surface of an implant, we don't use them, but around the abutment all the way to the top of the implant. Another thing when we're cleaning the implant itself is I like to use tie brushes. These are from Salvin. The tie brushes on the far left, these Nano brushes, I have found them to be invaluable at cleaning the surface of the implant. It's like using an SOS pad made out of titanium to clean an implant. They're absolutely wonderful. So getting into the repair implant technique, and it's very similar to treating natural teeth. You're going to wound the outer epithelium. You're going to remove the epithelium next to the implant. And then you're also going to decorticate the bone as you're troughing around the implant. You want to go in and decorticate the bone right next to the implant. And then if you have good access, you're going to use a radial firing tip or a lateral firing tip, and you're going to clean the threads of the implant. And this just goes through those steps. And then after an implant, we put patients on it's called IO rinse. It's an iodide rinse that patients can rinse with right after surgery. We found it works better for us than Peridex does. And we do low-level laser therapy the day of the surgery, a week after surgery, and 2 weeks after surgery. Low-level laser therapy on those sites. We found that it accelerates our wound healing dramatically, more so than when we're using PRP. So from my perspective, low-level laser therapy exceeds PRP in outcome. So getting into a case, my first recommendation is when you're accessing a case or when you're starting to treat a case, if it's possible, always remove the prosthesis. It is so difficult to work around the bulkiness of restorations to get good access to the body of an implant. And I try to treat as many of the implant cases as I can, minimally invasively. So I don't want to lay a flap unless I absolutely have to. My indications for laying a flap are if after you've troughed around the implant, you still don't have good access laterally to the implant, then of course we'll go ahead and lay a flap, as I'll show you in a case. But otherwise, we will use lateral firing tips and try to work within an intrabony defect without laying a flap. So in this case, I've removed the prosthesis. Then I'll trough around the implant with a erbium laser. And then I'll use a titanium brush to clean the surface of the body of the implant. And in this case, as I was cleaning the surface of the implant, I determined that I didn't have good access to the lingual aspect of the implant, to the distal. So what do you do if you don't have good access? You lay a flap. So that's the indication for laying a flap. Anytime you don't have good access to what you're doing, lay a flap. After we've cleaned the surface of the implant, I'm using an allograft material. In this case, I'm using a material called A-Cell. It's a two-phase putty. At room temperature, you can play with it like Play-Doh, and at body temperature, it turns solid. And so I'll place my graft around the implant, and then I'm covering my graft with a membrane, and I'm using an amniotic membrane. This one's a bio-exclude. Salvin makes a great one too called amniotic site. We found that even if these membranes become exposed, you don't lose your regeneration. Whereas if you're using a collagen membrane and it becomes exposed, you get a compromise of your outcome. In this case, I've placed my membrane and then I've replaced the prosthesis. So let's look at this on a different case on a video. Sorry about the noise. I had volume. Okay, so in all cases when I can, I try to remove the prosthesis. And if the prosthesis wasn't screw retained to begin with, I'll use diamond burrs. We have a kit called zirconia kit that will drill through, that works great on porcelain as well, and will drill through the crown and unscrew the prosthesis off the implant. And again, that just gives you great access, and it may make it where you don't have to lay a flap. And then I'll start by troughing. I'll wound the external epithelium, but then I'll start troughing around the implant. And as I trough around the implant, I'm actually doing, imagine treating a tooth, you'd stay right next to the root and trough around a tooth. Around an implant, you want a little bit more access than you do a tooth. And so I'll trough all the way around the implant initially, and then I'll do it again. I'll double the width of my trough, just so I have a flap that's easy to pull away. If I use a periodontal probe, I can place it in the flap and torque it away from the body of the implant. And so I'm just going around and around this implant till I create a wide trough, good access to clean around the body of the implant. And if it turns out I don't have good access to clean around the body of the implant, I'll lay a flap. And that's the titanium brush. That's a brush from Salvin. That's called their Nano brush, Nano titanium brush. And I'll use it with drip irrigation and clean the body of the implant. And it works a lot like an SOS pad. It cleans the body of an implant so well. And if you go back and look in the literature, the things that have been recommended to clean an implant successfully have been titanium brushes mixed with hydrogen peroxide in some of the studies, or just titanium or brush alone. And in our case, after we use the titanium brush, we also use ozone. I found that ozone cleans a defect better than anything else we've ever used. Now, this is ozone gas at 30 parts per million. And so after I've removed the granulation tissue and debris from around the implant, I've scrubbed the implant with my Thai brush. We'll also go in with ozone gas. We use this in extraction sites as well. We use this in our water supply in the office. We found that if you plate out your water to see if you have colony forming units in your water supply, you'll find that ozone mixed with your water sterilizes your water supply. The only caveat with that is you need to have silicone tubing for all of your things. Now, in this case, I'm going to submerge a membrane under the flap. So now I'm using a knife to create a pouch on either side of the implant, or a space that I can slide the membrane. And then after I graft around this implant, I'll place the membrane and retain it with a screw going through the middle of the membrane. So here I'm just loosening up the flap. And now you can see me using a periodontal probe as just a torquing device. And I'm using A-cell again. And I'm just squeezing A-cell all the way around the circumferential defect. This was an intrabony circumferential defect around this implant. So I'm just squeezing this A-cell around the implant. And again, it's a two-phase putty, so it holds its shape. Once you've molded it into place inside the defect, the graft becomes stiff. After I've placed the graft and I've tamped it into place, I'll take I think this membrane is an amniotic site. So I'll poke a hole through the middle of this membrane, and then I'll place it over the graft. I'll tuck it into that pouch that I've created facially and lingually, and then either retain it with the original crown, or I'll retain it with a flared healing abutment. And in this case, I'm using a flared healing abutment. So I'm taking this tooth out of pressure. So in our cases, if the bone loss around an implant is 25% or less, most of the time, I'll put back the original prosthesis and just use it to hold down my membrane. If I've got more than that, and I'm worried about as the bone starts to heal, you have a phase where it actually becomes soft, then I'll come back and cover it with this type of flared healing abutment, so the implant's under no pressure. Then after I've held pressure on the site, I'll allow the blood to clot and then I'll seal it with periacryl. It's important not to use periacryl anytime you see wet blood, because then the periacryl could make it onto the surface of the implant. You want everything to be coagulated completely. So that's the case that I have for you today, or the two cases that I brought to give you an idea of how we manage peri-implantitis. And we use these types of cases actually every day. In my practice, actually I have a before and after case here. Let me share screen one more time. Let's see. So this is a case that we did last year, and this is just a 6-month change in cases, but we went from 8s around an implant to 4s. So we're measuring we're actually probing to the top of the body of the implant, and let's see if I've got a type of implant case. So again, this is the type of case where I left the prosthesis on the implant, and I used the laser to clean around the implant. We grafted it, and then this is just a 4-month X-ray taken 4 months later. But you can see I've got graft that's coming up all the way to the top of the surface of the implant. And so I found that this approach is very predictable. I don't think it matters so much which allograft that you use, your favorite bone grafting material. I tend to like to mix bone graft materials. I like a bio-oss material mixed in with my allograft to give it body. And then I like to use a membrane over that graft, regardless of which allograft that you're using. So I don't think the allograft that you're using is magical. I think it really just needs to be a space, needs to save the space around an implant, and you need to protect it somehow with a membrane or some other type of material. So that's everything I have.
Great. Well, thank you, Bret. I know we're going to have questions. I have some questions. Our next presenter is Dr. Paul Chang. Paul has both, is boarded both in periodontics and prosthodontics. So this will be interesting because Bret did talk about prosthodontics. He is a graduate, boarded and a graduate from the University of Texas at San Antonio. He's in practice in periodontics and implants in McKinney, Texas. He actually has done a lot of work with zirconium implants. He knows about titanium surfaces. If I'm not mistaken, Paul, your research was on titanium surfaces at San Antonio. He also, in addition to being a periodontist / prosthodontist, he also has a taco restaurant that has some of the best tacos that I've ever eaten in my life. They're gourmet tacos. So if he wants to, he can talk. He can give you a little push advertising on his taco place when he's not repairing implants. So Paul, please.
Thank you, Dr. Lau, for the invitation. It is an honor to present this hot topic. Let's see, we got here. You know, we used to say implant lasts forever, but who has not, just like Dr. Dyer was saying, but who has not seen some sort of implant complications in their office these days? Do you know exactly what is the implant complication rate? Well, it varies significantly, depends on which literature you read. If it is a implant manufacturer sponsored study, you will see 90 to 95% success rate in 5 years. However, if you read some of the other studies, and based on my personal clinical observation and your personal clinical observation, the real world implant complication rate really is around 30 to 50% at 5 years. At 10 years, you will see even greater than 50%. The longer the implant has been in function, the higher the risk of developing implant complications. Here's another piece of evidence that shows you just how prevalent implant complication is. According to MAUDE, which is Manufacturer and User Facility Device Experience Database from the FDA, which contains volunteer reports of dental implant adverse event by manufacturers. The number of reported adverse events has increased from 12,000 in 2018 to more than 300,000 in 2021. That's a couple thousand-fold of increase in a short span of 3 years. Mind you, these are just reported implant complications. What about the ones that did not get it reported? I bet you that number will at least double. So what's causing this seemingly sudden exponential increase in dental implant complications? Well, this is a topic all on its own. But in short, the answer is we are placing more and more implants nowadays. And the implants are not only placed by surgeons, but also by dentists with varying degrees of training and skill sets. Not to mention, we have been placing implants and restoring implants for more than 20 some years. Lots of wear and tear. Nothing lasts forever. So how do we diagnose peri-implantitis and how do we manage it? According to the AAP, peri-implantitis is a pathological condition occurring in tissue around dental implants, characterized by inflammation in peri-implant mucosa and progressive loss of supporting bone. So clinically, you should see bleed on probing, suppuration, and then on serial periapical radiographs, you should see what? Progressive bone loss, like this case. On a mild peri-implantitis case like this, what treatment choice do we have? Well, we can watch it. We can do non-surgical therapy, such as scaling. We can do lipid using periolace from millennium. We can do implant repair using water lace from biolace, or we can do traditional regenerative approach published by Stewart and Fromm. So which one would you choose? But before we talk about treatment choices, shouldn't we try to determine the etiology of this bone loss first? Is it due to poor implant design that cannot handle functional occlusal load? Is it because implant was not placed properly? Did the patient not do a good job with his home care? Or was there excess cement? How about now? What should the correct treatment be in this case? What I'm trying to show you is that any and all peri-implant complications can lead to peri-implant mucositis and peri-implantitis. We must determine the etiology in order to manage peri-implantitis correctly. This brings me to Albertson's article in 2016, which he questioned if peri-implantitis is truly a disease, or is it bone loss resulting from many different complications caused by implant treatment itself, such as certain implant types, clinician error, patient conditions, treatment protocol, and quality of the treatment. In his opinion, peri-implant disease is a man-made disease / complication of having a foreign body placed in the oral cavity. What we're really trying to do here is to reestablish or maintain a balance between immune osseous system and the dental implant. Let's look at a life cycle of a dental implant. This is based on another article published by Albertson back in 2014. When we drill into the jawbone and place a dental implant, we create an acute inflammatory response. Our body can respond 2 ways. 1, rejection. This might be due to overheating of the bone, infection, or early load. Or we can achieve osseointegration, or what Albertson called it, a foreign body equilibrium, aka chronic inflammatory response. Our body has learned to coexist with this foreign object. However, this equilibrium can be disrupted during restorative phase, maybe due to sloppy clinical practice, due to poorly contoured restoration, excessive cement. If we intervene early and remove the offending factor, we can usually reestablish foreign body equilibrium without bone loss. If we don't do anything about it, then it will experience what? Progressive bone loss, peri-implantitis. The end result is the implant cannot tolerate occlusal force any longer due to severe bone loss and becomes mobile and infected, and the implant is lost. So how can we keep implant at this foreign body equilibrium stage? Well, just like Dr. Dyer said earlier, being meticulous from the start is the key. We need to stabilize patients' systemic factors first. We need to treat and manage periodontal disease first. And we need to idealize the implant site before we place the implant. Precise implant placement, not only apical coronal position, facial, lingual, and mesial distal. We need to have sufficient bone surrounding the implant. Lastly, keratinized tissue. We know without keratinized tissue, implants are more prone to experience peri-implant mucositis, peri-implantitis. Now, if we follow all of that, then I can comfortably say that implant will last at least 10 years or more without progressive marginal bone loss, such as this case. During restorative phase, we need to pay attention to detail. An ideal implant restoration needs to have proper emergence profile, like what the Dr. Dyer said, to avoid what? Excess cement and then aid in oral hygiene. We need to ensure there's no excess occlusal force on the restoration, as implant does not have shock absorption capability like natural teeth. Lastly, implant restoration needs to be retrievable because they will experience some sort of complication in their lifespan. It's just a matter of time. We also need to ensure patients know how to clean around their dental implants properly and then follow a strict protocol. Now let's look at this case. Within 4 weeks of delivering the final abutment crown, patient reported pain, tenderness around the gum line. What do you think is causing the pain and the bleeding and suppuration? That's right, excess cement. If we can identify the etiology and manage it promptly, we can reestablish the foreign body equilibrium. Now, if the patient does not follow proper maintenance protocol, it still could redevelop marginal bone loss in the future. Let's look at a mid-stage disturbance. This implant has been in function for several years. All of a sudden, patient is experiencing pain, bleed on probing, and suppuration between implant and tooth next to it. Tooth number 12 was removed. Implant number 11 was decontaminated using water-based laser, and bone augmentation was performed. What do you think the result will look like? Well, there are two possibilities. One, resolve clinical inflammation and total regeneration of lost marginal bone. Two, resolve clinical inflammation but incomplete regeneration of lost marginal bone. Since this case is still in its early stage, I was able to reestablish the foreign body equilibrium and regenerate almost 100% of the marginal bone. Again, patient needs to be placed on a strict maintenance protocol to avoid disruption of this equilibrium in the future. What about late stage disturbance, such as this case? Well, this is the case I showed you earlier. The patient has refused treatment until implants are at this stage, severe bone loss. Due to the severity of the case, I reflected the flap, removed the granulation tissue with water-based laser. I decontaminated the implant surface with water laser. And then after implant site has been decontaminated, I grafted the site with FDBA, layered with bio-oss collagen and the collagen membrane. The flap was then coronally positioned. What kind of results should we expect in this case? Well, with the late stage disturbance, where we already have some horizontal bone loss, even if we did reestablish foreign body equilibrium, it is still at a compromised state, such as this case, because it's almost impossible to regenerate bone vertically around an implant. So as a result, these implants are more prone to have to relapse, more prone to relapse. Okay, so exactly what is this maintenance protocol that I've been keep on mentioning? Let's take a look. This is the maintenance protocol I teach at my dental hygienist study club, and I use it in my office. When patient comes in for a cleaning, we need to check implant for prosthesis movement. We need to check for gingival inflammation. We need to palpate the gingival area to see if there's any bleed on probing or suppuration. If there is no inflammation, then the hygienist would proceed with implant maintenance using air powder abrasive, such as airflow, and expanding floss saturated with chlorhexidine. If there is gingival inflammation, bleed on probing, and or suppuration, then I would evaluate the soft tissue. Okay, if there's no keratinized soft tissue, I will perform implant repair using waterlays and connective tissue graft. So here's a case. As you can see, the prosthesis has been removed and the flap has been made. Again, waterlays laser was used to remove the granulation tissue. Implant surface decontaminated using waterlays laser and their patent side-firing implant tip. Defect was decorticated using waterlays laser to promote osteogenesis. Biomodification, here I used Amdigain, but you have a variety of choices, PDGF, PRF, etc. Bone graft, here I'm using allograft plus a membrane, collagen membrane. Again, soft tissue, connective tissue, harvest from the palate, and coronally positioned flap. Here you see before on the left, and on the right is 1 year after. Now, what if patient has keratinized tissue? Then we need to look at radiographic. Bone loss. If patient has radiographic horizontal bone loss and the probing is less than 5 millimeters, then I will perform an implant repair closed approach without reflecting a flap, because we know it's very difficult to, almost impossible to regenerate bone vertically on implants. So here my main goal is to decrease inflammation, help resolve the soft tissue. Okay. If patient has radiographic horizontal bone loss, but the probing depth is greater than 10 millimeter, I will perform implant repair now this time with a flap reflection. Why? Because if we cannot perform scaling root planing properly on a diseased root surface at that deep of a pocket, what makes you think we can clean a threaded implant properly at that depth? So again, these are implants with horizontal bone loss. Here, as you can see, the flap has been reflected. Here, I can clean the diseased implant surface properly because I can visualize the implant surface. Lastly, if there's angular bone loss instead of horizontal bone loss, then I will perform implant repair with guided bone regeneration. Here's the flap reflected, granulation tissue removed, implant surface decontaminated, and defect area decorticated, all using water-based laser. Bone graft of your choice. Here I'm using a amnion corneal membrane, and then coronally position the flap. Here you can see the dates on those x-rays. The pre-op, it's March 2020, and a year and a half later, 2021, is on the right. As you can see, we are able to regenerate some of the lost bone. So I end this presentation with a quote from Dr. Albertson again. Peri-implant disease is a man-made disease or complication of having a foreign body placed in the oral cavity. What we are really trying to do is reestablish or maintain a balance between immune osseous system and the dental implant. Progressive marginal bone loss, aka peri-implantitis, is a sequelae of peri-implant complication. There are many factors that can cause peri-implant complications. We need to correctly identify the etiology of this progressive marginal bone loss in order to formulate the proper therapy. And that's my new website, iFix Dental Implant. I thought it was pretty catchy. And if you guys want to follow me on Instagram, there's my iFix Dental Implants. Dr. Lau.
So did you stay up at night to come up with that? That's pretty good.
Well, you know, we got a couple of snow days, so I have nothing better to do but think about implants.
I believe it. Very good. Very, very good. You know, Bret, you mentioned that you're seeing implant complications once a day, at least once a day. Where are they coming from?
Everywhere. Just what Dr. Chang was referring to earlier. Everyone's placing implants today. And in many cases, I think a lot of the implant complications that we see are failure of site preparation. So extraction of a tooth without a ridge augmentation, or socket preservation. Placing implants in areas where the tissue is too thin or the bone is too thin around the implant. All those were things that could have been modified in advance of implant placement, but weren't. We're seeing less cement on implants because almost all the implant cases are being screw retained today, except for the anterior 6. But even the anterior 6 now, there are great prosthetic components to allow for angled screws. And so it's now quite feasible, quite easy to screw deliver 6 through 11. And so I'm always in favor of a screw retained restoration, much for what Dr. Chang mentioned earlier, is that we see so many implant complications over time. If we have easy access to them, it facilitates repairing them quickly.
Can you place an implant in 2022 without a CBCT and a surgical guide?
I don't. I think the standard of care is CBCT and guide. But I take that back to some degree. So say that a patient fractured off tooth number 8. You've got a CBCT, so you know what the volume of bone around that socket is. So you could extract that tooth, place the implant without necessarily a guided surgery, just using the information from your CBCT and placing it in the socket as you did on the computer. So there's still pre-treatment planning, but you don't necessarily have to have full guided surgery for an immediate replacement of an incisor.
So Paul, where are you getting your cases from? I know you're getting quite a few, and since you've got your new website up here, iFix Dental Implants, you'll even get more than you ever wanted. Where are yours coming from?
They are coming from patients, word of the mouth. They're coming from surrounding dentists, because I've given a couple of lectures on peri-implant complications. and a lot of just through that, really.
I know it's a sensitive subject, but both of you have alluded to it. And actually, you know, if you look at the new AAP classification, well, it's not new anymore, but the AAP classification on implants, they do have a category that's quite interesting, the fourth category, which is sort of like you placed it wrong and it screwed up, and it's really not about pathology, but it's everything else. So, you know, from that standpoint, how do you manage patients who come in with sick implants? I mean, so Bret, what is your, I can't imagine they're always happy.
No, you're always in less trouble if you start with the truth. And so if an implant was placed too far facially, or it's placed too close to another tooth or implant, or whatever, say the placement somehow is wrong, you know, I will tell the patient, I can repair or I can't repair this because of this. And so the way that we would manage that is I will unscrew that implant, rebuild that site, and then come back and place an implant after the site's been prepared properly. And so I kind of am just pretty straightforward and tell patients just that way. You know, in my own cases, say that I place an implant and we're doing our postoperative x-ray or whatnot, and I don't like the way I placed it. I get in there as quickly as I can and take it out. You know, if I can reposition it, place it that same day in a better way, great. If I can't, what if I just need to graft it and come back another day? I do it as quickly as I can. I think the faster you handle an implant problem, the less of a problem it will be. And I haven't had patients become angry with me because I did something and it just wasn't perfect, so I redid it.
So, Paul, when do you punt and take an implant out? What does it look like? What are the conditions to where you feel comfortable that you cannot do a repair implant with laser or what have you? You've got to take it out. What does it look like?
Yes, I did not include it in this presentation. I have another presentation that talks about when we perform the repair, when we take the implants out. But typically for me, if it's greater than 50 to 60% bone loss, if there's mobility, and if I don't feel like I can regenerate more than 50%, then that implant comes out. If I feel like the implant is placed improperly, if there's, say, if the implant has a short crown to implant ratio, if the implant is not placed in an ideal site or spot or position, then they'll come out.
I was very intrigued, Paul, with your slide about the FDA. Very, very impactful. So what is reported to the FDA, if I'm not mistaken, is from implant companies relative to adverse events. Isn't that what that is? That data comes from?
Correct. That's correct.
And so that data has to be fairly truthful. And I would agree with you. I'm sure not everyone is doing that. But my goodness, help me understand from 2018 to having something like, if I recall, like 12,000, and you pop up 3 years later and you've got 300 and something thousand.
So I recommend you guys go on YouTube and then Google implant complications, and then you'll see this news report from Arizona News. And basically what they found was before 2018, they have two separate databases. One is to the public. The other is not publicly available. For whatever reason, they categorized some adverse event as adverse event, and then the others as non-significant adverse event. After 2018, what FDA decided to do was make everything public.
Ah.
When you combine those two together, that also all of a sudden increased. However, if you look at it, after 2018, we still saw 2019, 20, 21, we saw 100,000 increase every single year.
So I'd understand from 2018 to 2019, but from 2019 on, it was
Every year is 100,000 more than the previous year.
So, Bret, you use a variety of things on the implant surface. Naturally, you use the erbium chromium YSGG and using the side-firing tip. What are you actually doing? What are you removing? Just from your perspective. I mean, there's a lot of ideas about what that is, but from your perspective, what are the decontamination, detoxification? What's going on there, especially with your brush, and then you followed with your, I think you followed up with your laser, right? You do the brush first and then the laser?
Correct.
So what's going on there? What are you trying to accomplish?
Well, because of the surfaces of implants are they're not porous necessarily, but they have lots of porosity. It's so easy to get things embedded, bacteria embedded into the surface of the implant. So I just consider it a huge challenge to clean an implant. And so I'm cleaning it every which way I can. And then when I finish, the reason we use ozone is I'm hoping to oxidize the surface a little bit to make it more biocompatible at the end. And so we finish with ozone for that reason. And
so, Paul, you mentioned a very hot area right now is GVT, airflow, etc. And so how valuable do you believe that is in your detoxification, decontamination? Because you're also using erbium chromium YSGG, and you had some great shots of the side-firing tip, but you're also using, if I'm not mistaken, you're using like glycine or erythritol air powder.
That's correct. That's correct. So we use that. My hygienist use that on every implant maintenance case, because that's really the only effective instrument that can clean subgingivally. Also, when your patient has a hybrid maintenance, hybrid restoration, really the only way to clean it without removing the hybrid is using the airflow. So we use that on every single maintenance case. And then I use airflow when I do my implant repair as well.
And so that's the EMS airflow device. I believe it's like the prophylaxis master or something of that nature that
Correct.
Also has the piezo device on it.
Correct.
Now, I think it's interesting, Bret, that you're using a diode around mucositis, if I'm not mistaken, if I heard you correctly.
That's correct.
But my knowledge of lasers would suggest that a diode, one would have to be careful utilizing a diode, because isn't erbium chromium like a photoacoustic, and a diode we begin to move into thermal. So help the audience understand how you're using that diode around mucositis, because in certain states, including Texas, a hygienist possibly could use a diode around an implant, maybe.
We use a heat sink, so methylene blue. So Listgarten did a study showing that methylene blue absorbs into the biofilm on the surface of a tooth or an implant, and also into granulation tissue. It doesn't really adhere or stain connective tissue. So if you place the methylene blue in there and use an initialized tip, when you place the tip of the diode subgingivally, everything that's stained blue will coagulate onto that diode tip instantly. So you're in and out of the pocket, typically in under 10 seconds. And also we're using the fast pulsing of the diode lasers from BioLase. So the high-speed pulsing is not really raising the temperature within the pocket in such a short duration of time. And by doing this, what we found, so we're being very aggressive with bleeding on probing. In my mind, once you have bleeding on probing, you have an infected implant. And so I want to reverse that process before there's bone loss. We found that when we use our methylene blue approach and then the diode, we can reverse that frequently.
So you are actually doing photodynamic therapy.
It is. Yes, it is.
So you're using your
Aggressive version of
methylene
it.
blue. I want to ensure the audience understands if they're not using laser, your chromophore, your target is the methylene blue. Your laser, probably 940 if it's an EPIC, is looking for the methylene blue, activating the methylene blue, and therefore you're getting the result that you want with a mucositis. Did I say that correctly?
You did. And because of the speed of the pulsing of that particular diode laser, you're not really raising the temperature inside the sulcus. You know, the studies have shown that if you heat up an implant, of course, you can actually cause cells to leave the surface of that implant. But if you're a diode laser at the proper settings can coagulate the biofilm without heating up the surface of an implant.
Correct. And so, Paul, in the augmentation part, are there times when you don't use augmentation? I appreciate both of you really sort of creating a generic environment. In other words, you do the augmentation, but you weren't really hung up on exactly the materials that were used, except you do. So in the augmentation aspect, so Paul, when is there ever a time you manage implantitis where you do not use augmentation of something or biologic?
Yeah, just like what I said earlier, if there's horizontal bone loss, then I would not use any, I would not graft.
So we have a question about something that is always on the tops of our minds, and that has to do with antibiotics. Could either one of you speak to both systemic and localized antibiotics? In other words, instead of using the laser for photodynamic therapy, Bret, would you ever consider using a local delivery antimicrobial? But also, would you ever, when do you consider using systemic antimicrobials? So Bret, would you start with, would you ever use a local delivery antimicrobial in 2022?
I don't. I really, my local delivery is the diode laser and methylene blue. I found that if you're using antibiotic spheres, you know, all the studies show a transient result. They don't show you a long-term outcome. Whereas when we're using the diode with methylene blue, we get a long-term outcome. But antibiotics are tricky today. You know, we have programs that we run, drug interaction programs for every patient now, because so many of our patients are taking a myriad of different medications for blood pressure, for heart, for arthritis, you name it, they're taking it. And there's so many new drugs that are coming onto the US market every single year. And so many antibiotics interact with these drugs. And so I don't think you can just give a blanket statement on which antibiotic you would use, mainly because the patients are already taking so many drugs that you can have a lot of cross reactions. So we're looking at that in every single case that we do. And if it's possible to do a case without using antibiotics at all, which is again another reason we use ozone, if we finish with ozone, many times we can let the patient use an iodide rinse afterwards and not prescribe an antibiotic. And we shoot for that anytime we can.
And so Paul, do you use systemic antibiotics in managing implantitis?
I pretty much am in agreement with Dr. Dyer. The only two things I will add is I treat peri-implant mucositis with my laser, except I use my water laser. I do a closed approach, basically the implant repair. I will give antibiotics only if I decided to augment, whether it's soft tissue or soft tissue and a hard tissue. When I get to that stage, I will prescribe antibiotics. But before that, no.
Well, this says, really appreciate your candor, both of you, your cases, outstanding. I have a lot of what I call take-home pearls in doing this. I do believe what both of you have established is that we can save implants. We can save implants. And I also enjoy your philosophy of not watch and wait, but both of you are really getting there very early, both of you, to aggressively. And I appreciate, the comment that was made about this is not periodontitis. This is much more episodic, much faster, and you just can't monitor this. So I really thank both of you for being with us tonight. And I thank all of you who are on this webinar tonight. It is being recorded and you can see it at a later date.